I'm Sanjay Patel. I'm a consultant in paediatric infectious diseases and immunology at Southampton Children's Hospital, and I also lead a program called Healthier Together. Hopefully, many of you have heard about and are using. And I'm joined by Holly Green. Holly is a midwife at UHS and is also the maternity lead at Healthier Together. And over the next kind of 45 or 50 minutes, I plan to sort of talk about quite a focused talk about some of the respiratory stuff that's going on, in the context, obviously, of COVID, because that's been almost the only show in town for the last 18 months. But things are changing, and so to just have a little think about what happened during the COVID pandemic in terms of paediatric urgent care activity. Um, what we think is going to happen with bronchiolitis and RSV this year, and then go back to our users, to parents, and where are we at with their confidence in terms of managing poorly children, and then the importance of consistent approaches across the urgent care pathway that includes health visitors, pharmacists, GPs, NHS 111, the hospital, etc. So that's what we've really tried to promote through the Healthier Together program. And then I think it's quite useful, and hopefully you'll find it useful, doing a bit of a refresher on our approaches to children with shortness of breath and cough, as well as children with fever, because we found that those are the two presentations that have really brought parents to seek a healthcare consultation in droves over the past few months. Holly will then kindly talk about some of the resources that will help you look after some of the postnatal women. And then a little bit about implementation and things that you can implement now that will hopefully help support the coming weeks and months. So this is a bit of it's a graph showing rates of attendances of children to ED of 0 to 18-year-olds. And what you'll see is you'll see lots of lines, and lots of those lines are near the top, and that's all the previous year's attendances, Q1 being April, May, June, Q2 being July, August, September, etc. So the winter months are essentially Q2 and Q3. But you'll see that this green line is much lower than all the others, and that's the impact of COVID. Q1 2020, 2021 was April, May, June of last year, and that was when there was a huge concern about COVID and transmission, and we saw a huge drop-off in children presenting to ED. That sort of persisted and resulted in a great amount of concern amongst healthcare professionals that there was a whole swathe of children who were really poorly at home, who were going to come to great harm because their parents were too scared to bring them to seek a healthcare opinion, either in primary care or in ED. We looked into that into a lot of detail, and that didn't really happen. And the reason for that is that many of the things that make children poorly, and RSV is one of a number of viruses that cause bronchiolitis, and bronchiolitis is the most common reason for being admitted as a child over the winter months to a hospital. It completely disappeared last winter, and you'll see that the most obviously absent thing is a big spike of that green line in week 52. Usually we get our peak of RSV around just in December towards Christmas. And every year we either have kind of mild RSV or mild bronchiolitis years or more severe ones. And last year we didn't have one at all, which was absolutely extraordinary and was highly not predicted, but just shows that the impact of social distancing had on transmission of not just COVID, but all viruses. And so that was probably one of the main reasons why we saw such a sharp reduction in presentations to ED and to primary care. But unfortunately, it's not all great news, because these are data from Australia, and that black line is an average over the last 20 years in Australia of RSV cases. And you'll see that they're in the southern hemisphere, not the northern hemisphere, so their winter is in our summer. So weeks 25, 6, 7, 8. So that's sort of July time, July, August. They expect to see a large number of children presenting with bronchiolitis. And you'll see the red line that in the year 2021, over their classic winter, they saw, same as us, no quick cases of RSV. But what they did see instead of that was this unseasonably sharp rise in their summer. So their summer is the equivalent to our winter, and suddenly in December of last year, they had a large number of children presenting to their hospitals and to their primary care practitioners with what looked like bronchiolitis, and on testing was RSV. And you'll see that they saw a very high peak, and they saw a very sharp peak, which meant that their services were almost surged due to RSV. And this generated huge anxiety in this country and a number of other countries about what was going to happen in our summer, which is now coming to an end, albeit it's very hot and sunny outside, and coming into autumn. The other bit of note is that bronchiolitis classically affects children up to about a year of age, but they were seeing children up to about 2 years of age presenting with classic bronchiolitis. And that was thought to be because that whole group of children were never exposed to RSV in their first year of life because of that absence of infection. And so it pushed out the phenotype of bronchiolitis to a little bit older, so up to about 2 years of age. And the bit I should have said is that all this various color coding links in with the different COVID approaches that were taken in Australia at the time. So they closed their borders in April time, a bit like us, not with borders, but that's when they implemented some very early on, March, April time, some border closures. They had total lockdown initially, but they came out of it quite quickly. And in that period 3, they started opening their schools, albeit with bubbles and social distancing, etc., in place, as well as things in society. And by period 4, they were pretty much back to normal in schools, and most of their social restrictions had been lifted too. So it was in the face of an easing of COVID restrictions, that out of season, when it was hotter than usual, so in their summer, that they saw this large peak in RSV. So just as a reminder, what did we do in the UK and what were our timelines? And it's quite hard to remember, is the honest truth, because we've done so much over the past few months. But we started the roadmap for lockdown in about March, when we opened schools, which was fabulous news, and we allowed outdoor mixing. And that was the rule of 2 initially, and then to the rule of 6 quite rapidly in March. We then had step 2 in April, which was indoor leisure being opened. In May, we had the rule of 30 outdoors and the rule of 6 indoors. And since the 21st of June, we've had removal of most social restrictions. So we are at that point, similar to Australia, where we now have lots of mixing of people and a risk of transmission of viruses. And what we saw in the UK was from about May onwards, even April, May onwards, as well, following the opening of schools, we saw a large number of children being brought to ED. And this is a statement by the various Royal Colleges of Paediatrics and I think nursing and emergency medicine, saying that we've got lots of actually relatively well children being brought in with fever, mild fever, by anxious parents, and that there was a real push to try and get them seen in primary care again and try and increase the confidence of parents to do what they have done for years and years. And the feeling here was that parents had sort of lost their confidence, had sort of de-skilled a bit, because they just hadn't seen their child ever having had a fever in those first 2 years of life because of all those restrictions due to COVID and the massive reduction in circulation of viruses. And you know, to almost highlight that point, in Bristol, in that week of the 17th of June, they had their busiest week ever. And that's, you know, even comparing it to their busiest week in the middle of winter. So they set a new record for the number of children seen in 24 hours in their department. But I think what's important to realise is these children at that point were not particularly sick. This was the worried well. And these lines refer to a score that's to do with having normal vital signs, no nursing requirements, and no relevant past medical history. And you'll see towards the right-hand side of that graph that that percentage is extremely high. So really, really well children, and this is data from a friend of mine in Leicester who runs their emergency department, loads of children being brought to the emergency department who were just really well, and actually with some sensible resources available to parents and ability to reinforce their confidence, could have avoided coming to primary care or even, or in this case, secondary care. And I think one of the issues, and it's still an issue now, is that it's primary care is really struggling, and they're struggling because of all of the COVID infection control restrictions. It's very hard for them to see a significant number of people face to face, children or adults. And I think that inability to be seen face to face has resulted in parents voting with their feet and increasingly bypassing primary care and coming straight to secondary care, which is an issue. And I think it's as important, if not more important now than ever, to try and really reinforce parental confidence so that they have access to resources that they can refer to when their child is poorly, and that can hopefully give them enough confidence that their child isn't so poorly that they need something doing, some sort of treatment, and they're not going to come to any significant harm. So what's the current situation? So that data was when we had other viruses like rhinovirus, when all the schools opened and we had a load of snotty children, many of whom had fever. But things are a little bit different now because we're starting to see a few unwell children, and we've got 7 children on our paediatric intensive care unit in Southampton, that was yesterday, who have RSV bronchiolitis. And you'll see from this graph that this is the kind of UK data, and we're now seeing an increase in cases of RSV, which was predictable based on the Australian data. The Northwest was the first bit of England that saw a sharp uplift in cases. That happened before schools broke up, so that was in about end of June. They saw a very high rate of bronchiolitis, but as you can see from this graph, it went up very quickly, but then came down very quickly as well. So it didn't surge their services particularly. But what's worrying is that compared to the previous years in the Northwest, it was a very high peak, albeit a peak for a very short period, and then down to kind of a normal bad RSV winter. So worrying, but also reassuring that it didn't surge their capacity. In the south of England, we over the summer have seen a steady increase in cases of RSV in young children. But when you compare it to our sort of previous year's rates, it's still not as high as that. But I think we're pretty much at the point where we're a moderate RSV winter with 7 cases on PICU. And I suspect if we continue to go up and up, and the concern there is with schools having reopened either last Thursday or yesterday, we may see a significant uplift in cases higher than normal seasonal averages, which may put significant pressure on our services. And some of those babies will obviously be presenting to you and maybe in the various groups you run. So I think this is the challenge. We've got the art is reassuring the worried well, because we do need to maintain our capacity in ED to see some of these children who are actually poorly, who may well have RSV and may well have bronchiolitis or severe viral-induced wheeze that do need to be managed. And so that's where all of us have a responsibility. And I just want to talk briefly about Healthier Together and how we've used an evidence-based approach to try and tackle this. Important to know why parents seek a healthcare professional. And I think that is fundamentally important if we're going to try and convince them to change their behaviour. And it's because they perceive a health threat to their child. And that's why all of those parents brought their children in May and June to the various EDs across emergency departments across the country. They saw their child had a fever and they thought, oh my goodness, is my child septic? Do they need antibiotics? Is harm going to befall them? And so parents recognise they lack confidence in distinguishing self-limiting illnesses from serious ones, but they believe that clinicians can, health visitors, pharmacists, GPs, paediatricians, that they see as our role, which to some extent it is. But this is the other bit that's important. If we're trying to bolster parent confidence in their own instincts, well, if we as this unified healthcare provider, the NHS, give very inconsistent advice depending on who you see, well, that will obviously erode parental confidence, and they will then obviously seek a healthcare consultation. And this is a great example of what will happen if we all do things differently. And this is, I rushed him down to the doctors, and apparently both his tonsils were inflamed and he was put on antibiotics straight away. I felt dreadful, and I said, how did I miss that? And I think from then on I can't have him suffer like that next time. And this example relates to prescribing of antibiotics, which in this case with a young child was very likely to be inappropriate. But all it's done is driven future health-seeking behaviour. And us being very inconsistent in giving parents advice achieves something very similar to that. It just simply erodes confidence and increases anxiety. We've also, through the Healthier Together programme, really sought the views of parents and healthcare professionals to ensure that the programme aligns with what they want and what they need. And so parents have requested online resources, a website, an app. They want some information and education on common illnesses, and they want consistent advice from healthcare professionals more than anything. And the professionals, and this was, GPs and paediatricians and community nurses, they wanted standardised resources for parents. They wanted access to clinical pathways which were consistent, so that we're all doing similar things. We've got similar thresholds for referral. We give similar information to parents, and they wanted training and updates. And that's obviously something we're doing now, and that we've done very similarly for GPs and practice nurses and community pharmacists and paediatricians in the hospital and NHS 111 staff and paramedics. We use these pathways that I'm going to show you to train all of our staff, so that we're all generally doing something similar. And as I said from that slide, that's what parents expect and should expect from us, an element of consistency. And that links into what the whole program's trying to do. We're trying to empower parents so that if a child's sick, they bring them to the right place, which may be an emergency department. It may be calling an ambulance to get timely treatment initiated in a timely fashion. But it also flips to a child that's got a self-limiting illness, for the parents have enough confidence to manage them at home, but to know what signs and symptoms to look out for and what should then necessitate them seeking a healthcare consultation. Being signposted to appropriate services, not just ringing an ambulance each time. And it's also, we're really keen to work with the people that deliver or support families, so that we can increase their competence and where to seek advice. And we're trying to achieve parents receiving consistent and appropriate advice across the whole urgent care system, and with local pathways working. And we've done that in a number of ways. We've created a website. We've been running the program for about 6 or 7 years now. It's a kind of nationally used resource. You just have to type in Healthier Together into Google, or that slightly complicated URL that's just above it, and you'll see it's a very parent-facing looking website, and that's for obvious reasons. We want to really market this to parents, but within it you'll see on that toolbar that it's got a tab for professionals, and I'll come to that in a bit. Within that tab for professionals, so within the parent bits, for all common illnesses, for babies and for children, we've got information. We've filmed a number of videos. I think these videos are really useful. They're a health visitor, so it's Sally Hintner from Southern Health with Ollie Morris, who's a GP from Southampton, talking through a whole array of common presentations like cough and cold and diarrhea and vomiting and abdominal pain and stuff like that. And it's all found, parents find those sort of videos as a really good addition to some of the written information on the website. Obviously, all the information on the website can be translated to any language on the planet, essentially. We've got these pathways, and I'm going to go through the bronchiolitis pathway and the fever pathway just as a refresher later on. And we've got safety netting resources that use this red, amber, green approach that you can already see on the screen. And that's so that when a parent searches the website on the parent-facing pages, they get essentially the same as the healthcare professional will share with them after a consultation. And that will hopefully mean that they feel that actually much of the things that are done, they could have assessed at home themselves, and not sort of had to go to the trouble of then having to contact a GP or try and make an appointment or call up the practice, etc. So it's trying to empower parents with education being a big part of it. And on the website, and I'll mention this later as well, for all of our pathways, for all of our remote assessment pathways, we've got a whole series of training videos filmed by David James, who's one of the emergency medicine consultants at Southampton and who's the acute care lead for Healthier Together. And I think the proof's in the pudding in terms of, the impact of the programme. And this is what we've heard when we've interviewed parents about the Healthier Together resources. You know, it's so clear, isn't it? It's simple, it's in your face. You start at the bottom, you tick them off, and you go up and start ticking them off and say, okay, this is the point I've got to. You needed to go to the doctor, or we've got pain and diarrhea but no vomiting and nothing else, so we're all right. I think it's really well laid out and really clear. You can't get confused, can you? And this is what, you know, we all of the feedback from parents, not just in Wessex but nationally, is that those red, amber, green tables are the most, what they find the most useful and clear and valuable. And a view from a clinician, this is a GP from West Hampshire, a fantastic resource for me as a GP day to day, having standardized guidance that I know that health visitors, GPs and paediatricians are all using, helps with the consistency of messaging to parents. Also being able to text parents a link to the guidance is extremely valuable when giving telephone advice, adding weight to safety netting and allowing parents to take control of when to seek more help with greater confidence. So, you know, lots of good bits. You know, it has had an impact on health-seeking behaviour. This is some data from pre-COVID, where over the time we've implemented Healthier Together, we've reduced presentations to primary care by 10%. We've reduced admissions to hospital so that we're even lower than the national average, and we've reduced antibiotic prescribing in primary care, which, if you remember that quote I said before, also has an impact on future health-seeking behaviour. So, you know, I think this approach of consistency, red, amber, green, has proven very useful. I think parents have got a little bit out of practice because children just haven't been that unwell for a number of months because of the COVID social distancing measures. But now that children are getting poorly, we just need to remind them about some of that stuff. So as I said, consistency amongst professionals is super important. If you click on that tab for professionals, you'll see a drop down of essentially all of the professionals across health and social care who are integral in the care, delivering care to children and families. And under the health visitor tab, you'll see a whole myriad of resources there, paediatric pathways and pregnancy pathways and remote assessment pathways, which are probably the most useful resources for health visitors. Within there are the training videos on common conditions. We've got all of our safety netting resources, things on the postnatal mother and baby check, emotional, mental health well-being, information sheet on medications, safeguarding. So, and at the bottom there, you know, information about should a child go to school or nursery. So loads of information that is really useful to share with parents. And as I said, this concept of consistent information and everything being available on the parent-facing bit of the website really facilitates shared decision making. So there's no secrecy, you know, everyone's got access to everything. I wonder if at this point I'll take just a tiny break and see if anyone's got any questions. You know, just sing out, put up your hand. I can see the screen now. Okay, there's a lot of text in the chat box. Oh, that's actually okay. Any questions, Holly? Is everything all right so far? Can you hear?
Yeah, all good, Sanjay.
Okay, fine. Let me carry on. And Holly, can you can still see my PowerPoint slides? Yep.
Yeah, we can.
Fab. So let's go on to what's likely to be the challenges we face in terms of physical health in children over the coming few weeks and months, and that's not just RSV but other respiratory viruses. As you've seen in the last few weeks, we've seen an uplift. We've got lots of children in Wessex with them, and And it's useful just to have a reminder of what bronchiolitis is and what viral-induced wheeze is. So bronchiolitis is common. Most children don't get desperately sick with it, but a proportion end up coming to hospital, and a very small proportion end up being admitted to needing ventilation on an intensive care unit. It usually affects babies up to about a year of age, but I think this year, and the data from Australia suggests it's going to be a little bit older than that, probably up to about 2 years of age. It often starts with a runny nose and then develops into a cough and breathlessness. And often, as with most viral infections, there are other people in the family that have been unwell. So it might be an older sibling who's been at school that brings it home, or a parent that's been at work, or whatever. So often a story of someone else, other people in the family who have got a viral infection. The things to look out for is their breathing, obviously, and difficulty breathing. The easiest sign is their rate of breathing. So, if they're breathing at more than sort of 40, 50 breaths a minute, that's a worry, but also their work of breathing. So if instead of lovely abdominal breathing with their sort of stomach going in and out, which is the most comfortable way for a baby to breathe, you start seeing them sucking in under their ribs, we call that subcostal recession, or tracheal tug, which is where you see their kind of windpipe area sucking in and out, or if their head is bobbing. All of those are a concern. If they're grunting, which means when they breathe out, they make a sort of funny grunt noise, that sort of noise, that shows that they're finding it hard to breathe, and they're trying to put other measures in place. In that situation, they're breathing against a kind of closed epiglottis to try and keep their airways open, and that really is a sign that a child is struggling to breathe and needs onward referral. Often it gets better, it gets worse before it gets better. So a child, if you're seeing them on day 2 and they're already a bit borderline, it's quite likely that they might slightly tip over the edge in the next day or 2. Often for children, the thing that's most evident is their ability to feed. So if they're breathless, they start finding it hard to feed. So that's kind of quite a nice sign to ask about. The children we worry about most are young babies, so children under 6 weeks of age, and nearly all of the ones we've got on PICU at the moment are under 6 weeks of age. So that's because their lungs are just so small that when they get clogged up with all of that gunk, it really results in severe respiratory distress. But also children with chronic lung disease, congenital heart disease, extremely premature babies. But a number of them will be receiving the immunoglobulin, the palivizumab, which is RSV protection stuff. That started about a month ago in the UK and is going to run through till about March. So many of the children with severe comorbidities are already getting a bit of protection. And unfortunately, there's no treatment for RSV bronchiolitis. You just support the child, which means that they're not going to get anything magical in hospital. But clearly, if they're too breathless to feed, we will support their feeding with an NG tube. And if they are hypoxic, we will give them oxygen. And that's what we mean by supportive care. And if they've clearly got severe respiratory distress, we may need to support their breathing with various things like non-invasive ventilation or even invasive ventilation. The other group of children you're likely to see is children with viral-induced wheeze. So that is very common. That doesn't mean they're going to go on to develop asthma, although some of them might. Often, once again, starts with a runny nose and then just makes their airways clamp down a bit. Similar, they may have respiratory distress, but you might hear them wheeze on breathing out. Although for slightly older children with viral-induced wheeze, they sometimes respond to things like salbutamol. Our experience so far is with the bronchiolitic babies with RSV that have wheeze is that bronchodilators haven't really made much of a difference. So once again, it's predominantly supportive care. But just the take-home message from this slide is that it's respiratory distress, feeding, and getting a feel for how much they're struggling to breathe will really inform the decision about whether they can be managed at home or whether you need to refer them to primary care or ED. And a lot of that information is put in more detail on this slide. This is the remote assessment pathway, which you'll find on the health visiting section of Healthier Together. And it breaks down, it sort of stratifies severity of bronchiolitis into red, amber, green. And let's start with the red because it's clearly the most important. And these babies need to be brought to the attention of an emergency department quickly because a child with severe respiratory distress could rapidly have an apnea and something like that. So if they're blue or grey in colour, if they're unrousable or difficult staying awake, if they've got weak, high-pitched cry, continuous cry, all of those things in a child with bronchiolitis should concern you. As I said, grunting, which is an extension of an indication of severe respiratory distress. Breathing very fast, so breathing rate of more than 70 breaths a minute. Pauses in their breathing. Or if their intake is so diminished because they're so breathless, they're not getting in even 50% of their usual intake over the preceding 2 or 3 or 4 feeds, then those children need to come up to ED because we need to support their breathing. That can't be done in primary care. It can't be done at home. If a baby's too breathless to feed, they're going to get dehydrated otherwise. And the other one is any baby under 3 months with a temperature of above 38 degrees or above. And that's because there are some babies who will have sepsis, who will appear to have bronchiolitis. And we do worry about all babies with possible late onset sepsis. In terms of counting babies' breathing rate, if you're doing this remotely, it is important that you shown a parent how to count a baby's breathing rate accurately. And if you look at the resources tab on the website, you'll see clips to common videos, and one of those is counting a child's respiratory rate. So you could potentially share that with a parent and get them to count the breathing rate when you're on the phone to them. Similar things to look out for. So, essentially you're looking or asking about the colour and activity of a baby, how hard they're finding to breathe, how fast they're breathing, whether they're dehydrated, what their urine output's like. And once again, thinking about these risk factors. And I would I'd always get, for a young baby with bronchiolitis, anything that's nothing more than a runny nose, I would be, safety netting them clearly and ensuring that if there is deterioration, that they do seek the input either of primary care if it's just amber features that develop, or ED if it's red features, because they are at a far higher risk of needing support with their feeding and oxygen and breathing. This is the safety netting sheet on the website, and you'll see that it essentially says all of the same stuff as on the clinical pathway. So you may decide that this is what you use when you're assessing a child remotely. You just go through some of these questions with a parent, and if they're no amber or red, you simply SMS share the safety netting sheet to them, and thus provide them with very clear instructions of what to look out for and what should trigger them to seek a GP appointment or to come straight to ED, which is amber or red respectively. Within the safety netting pages, and this is the parent page, this is the safety netting page. It's got information about how you can look after your child, information about bronchiolitis. So within the look after my child, it's about little and often. So, when a baby's breathless, they're not going to do a full, 4 or 5 ounce feed every 2 or every 3 hours. They're going to need smaller volumes and more frequently, so you can provide them with some guidance about that, how they can help their baby, and how long bronchiolitis is likely to last. And as I said before, if you share the parent-facing page with them, there's also really useful video information as well as written information. This is the this was supposed to be the fever pathway. The fever pathway, I'll go to on here. So we've got resources. So the other thing that's likely to present and parents are going to be worried about is their child having a fever, as I said, because few children have had fevers over the past 18 months until schools have reopened. And so in this situation, you're really trying to rule out sepsis, and sepsis is just inadequate perfusion. They'll have cold hands and feet. They'll be drowsy. They will be struggling to breathe potentially. And so the guidance on here is what you could probably should go through. There's a clinical pathway on fever for remote assessment and face-to-face assessment as well. And just as a reminder, the baby under 3 months of age with a temperature of 38 or above, unless they've just had their vaccines in the preceding 48 hours, their 2-month vaccines, and they've got no other red or amber features, all of those should be referred to secondary care, to ED, in case they've got late onset sepsis.